Welcome back to Airy Bros Radio. Today we have in-studio guest, Dr. Wachholz. How you doing today, Doctor?
I'm doing quite well. Thank you for having me.
Thank you for being here. Before we get into it, just tell us a little about yourself and your background.
Sure. So I'm an associate professor here in the psychology department, and I'm a clinical health psychologist by training. And my passion really is in finding better ways of treating comorbid pain and opioid use disorder. And so all of my research, my clinical experience have all been to that end of finding a better way to treat this very complex disorder that has grown up very organically, both in the United States and around the world. And that for the longest time, we didn't have any ideas of how to solve this problem. And so my goal is to see if we can start finding some better solutions.
And what are some of those solutions?
So some of those solutions that we've been finding, at least in our research, is to begin with an understanding that pain and opioids actually run through a lot of the same system in the body. So when your body is experiencing a lot of exercise or something like that, if you ever know anybody who's ever had the quote-unquote runner's high, that's part of the endorphin system. And what that means in Latin, you didn't think you'd get any Latin here today, what that stands for is that's endogenous opioids. So that's the system in your body that it makes you feel good whenever you're exercising, whenever you're feeling a little bit of pain. It helps balance that pain and suppress it a little bit. And so that's a natural system that's already in our body. The problem is that when opioids from external sources come into play, they're hijacking that system that is already in place. And so what happens when somebody's struggling with both pain and opioid use disorder is you're hijacking the endogenous opioid system that's already in the body. You're overwhelming it, but at the same time, you're not completely treating the pain issue that caused the initial desire to seek out opioids. And so it becomes this almost catch-22 situation of how do you treat the pain while at the same time not escalating an opioid use disorder, and all in conjunction with the fact of you're working through many of the same systems in the body. And so by the time you raise the opioid levels to the point of potentially assisting with the pain, you're also getting a lot of side effects alongside there. So not only are you having problems with pain, there's now craving issues because of the opioid use disorder. There is now issues related to what's called hyperalgesia, which is once the opioid system gets very activated, the body changes, and so people actually become more sensitive to certain kinds of pain. And this is something that has been well known in the research literature, but not as well translated into the clinical literature lately, until recently, is that taking elevated levels of opioid actually make you more sensitive to certain types of pain. And so then oftentimes patients are then chasing that pain treatment by using more and more opioids to try to treat that pain treatment that's actually a side effect of the opioids that they're using. So the first step in solving the problem is understanding the problem. And so we're starting to get a better understanding of all of these very complex phenomena that's happening in the body. And it's not just a physical system. There's also obviously the brain that's involved as well. Opioids can have psychological consequences as well. They can cause that sense of euphoria. They can cause a sense of mood escalation where people feel good. It can temporarily make people forget any other difficulties or struggles that they're having in their lives. And so it becomes sort of the single solution when people are sometimes having struggles, is that they look for this little magic pill that's going to take away all of the problems, at least for a short period of time. And so again, part of the understanding of better solutions is first really recognizing and having a really good understanding of all of these very complex and intertwined psychological, social, and physical phenomenon that are happening. And based on that, then we can start developing better treatments. And so when I started my research 15 or so years ago, my background was in pain management. I was trained in pain management. I did pain management psychology, and started noticing that when patients started struggling with opioids, they had a lot of problems, and then they were just getting discharged from these pain clinics. And I started asking, and I was still a trainee at this point, so I started asking questions of, so what happens to patients when they're discharged from the pain clinic? And I was told, oh, well, they go seek addiction treatment. But the difficulty is that addiction treatment providers aren't trained in pain management, and pain management providers aren't trained in addiction, especially when I was undergoing training. And so even if patients got discharged and they get the addiction treatment, they still wouldn't ever have the pain treated. And so this, again, another catch-22 for patients. And so being the dutiful trainee that I was, I went to PubMed and Google Scholar and really typed in, like, what do we do? What's the cutting edge for patients that are struggling with this disorder? And, eureka, there were thousands of articles, and I was really excited about that. And then I started reading through the articles, and all of the articles were opinion pieces on, yep, we got a problem with that. Gee, don't we have a problem with that? Wow, somebody should really do something about that problem that we're observing. But there wasn't actually any solutions, which was very frustrating to me, especially as a trainee, because I was like, well, somebody has got to have discovered something that would work. And being very frustrated with the state of the literature, again, this was about 10, 15 years ago, I said, okay, well, I guess I'm going to start researching this area and see if we can come up with better solutions based on the very little pieces of data that we knew. And so I started with, let's look at physiologically what happens to individuals who are struggling with comorbid pain and opioid use disorder. Let's find out what happens to their body when they do go into a pain crisis. What happens when they do experience cravings? What happens to their heart rate? What happens to their blood pressure? What happens to them physiologically? And then use that information to create a more targeted treatment protocol that can address both what's happening with them physiologically as well as psychologically and socially. And so that's where I'm very excited. Now we've been through a number of study series, really looked at the physiology, really looked at patients that have in the past struggled with opioid use and chronic pain and are still struggling with chronic pain but have been opioid free for 6 months at minimum. In our particular study that I'm thinking of, they were opioid free at least 2 or 3 years, and they were maintaining that opioid free even in the context of significant pain. And so the next step was to ask those individuals, okay, what are you doing? Because they're the success story. They've somehow managed to struggle with opioid use disorder, come through the other side, maintain an opioid-free status. They still have their chronic pain, and yet they've found techniques, tools, psychological strategies, behavioral strategies to continue to live their daily life. And so we did a lot of talking with that patient population. And the combination of what we learned from the physiology studies and what we learned from this very generous patient population that were willing to share their stories, their history, and their own psychological and behavioral strategies, we developed a psychotherapy treatment program called STOP. And it stands for Self-Regulation Therapy and Opioid Use Disorder and Pain. So if you, it's
Say
a very
that 3 times fast.
Exactly. I was sitting there trying to come up with an acronym, and I was sitting in an airplane seat, and I'm sure writing on the back of a napkin, and I'm sure I scared whoever was sitting next to me in the airplane seat as I'm trying to come up with that acronym for STOP. But I promise that self-regulation therapy for opioids and pain, it does eventually come out to STOP. So we developed that, and it's been through a couple of pilot trials now, and we are very excited about it. It is the only one, to the best of my knowledge, that is a psychotherapy treatment that is built from the ground up from the physiology, the psychology of patients that are struggling with opioid use disorders, that specifically goes in and treats those key components that make that population different than individuals that are coming straight with opioid use disorder or straight from chronic pain. This combination, this comorbidity, creates unique physiological and psychological challenges. And this psychotherapy treatment program is designed specifically to treat those unique pieces that the patient population is struggling with. And it's a 12-week psychotherapy group. We're actually still recruiting for that study at this point. We're into our third iteration of the psychotherapy treatment trial, and we are still recruiting for that. And it's a 12-week psychotherapy rolling entry, so the moment somebody's ready to get help, we can bring them into the study. They don't have to wait until the next cycle comes through or anything like that. If they're ready to get help, we can take them in immediately. And that's one of the solutions that, like I said, I'm very excited about, and it's designed to be done in a community addiction treatment center. It comes with training protocols and teaching protocols for addiction treatment providers who are excellent at addiction treatment. That's been their training. That's where they've come up. But they've got no training whatsoever in pain. And so part of this treatment protocol also involves training providers. How do they work with patients that are struggling with pain, and what are some of the major techniques and strategies that have been scientifically supported in working with patients that are struggling with pain? So it's kind of a two halves of the same coin, and we're going to need both halves of the same coin if we're going to successfully treat comorbid pain and opioid use disorder at the same time.
So how do we treat pain? Is it giving someone something else? Is it exercises? How are we going about that?
There's a couple of different ways, a couple of different inroads that we can make for pain. So certainly with the primary goal of the study is to help patients get their lives back. That's the number one goal. It's not just pain management, because if the only goal was pain management, we can knock people out. We can put them into medically induced comas. And nominally, that would take away their pain. But that's not helping them get their lives back. And so the end goal is helping people do what they need to do to get their lives back. And part of that then is helping them develop cognitive strategies, behavioral strategies, and psychological strategies to better adjust to their pain. So there's a part of the brain that is, there's a couple of big pieces that are involved in this, but one of the major areas is called the anterior cingulate cortex, or the ACC. And it really acts almost like a volume button for pain, that the brain takes in the pain signals that are coming from the body. And this part of the brain can decide to either dial up or dial down those pain signals, and it affects the ultimate pain experience that somebody has. So most people have had the experience, even if you're not a chronic pain patient or anything like that, most people have had the experience where they've been busy, they've been active, they've been out hiking or something like that, and they wake up the next morning and they've got a bruise, right? Most people have had that kind of experience. And now it's not a question of, did you do tissue damage? Because you broke blood vessels, so that's why you have a bruise. But because your brain was so busy processing other things, your brain turned down the pain signal. And so the pain experience for that incident is minimal. You didn't really have a pain experience. So that's why you wake up the next morning, you got a bruise, and you're like, where'd that come from? On the other hand, sometimes people might have had the experience of it's late at night, it's dark, you have a bed partner, you're trying not to wake up, and you're trying to run and grab a drink of water or something like that. And so it's dark, it's quiet, you're being very careful about moving silently through the room, and you stub your toe on the corner of the bed. And it hurts like wildfire.
Been there.
And you may have even said a few choice words. We all have our favorites through that, because your brain was so focused on what your body was doing, and your brain was so devoid of any other external stimuli. It's dark, it's quiet. That anterior cingulate cortex dials up the volume. And so what might not have been a really bad stub of the toe feels horrible. But again, if you had that same stub of the toe while you were out hiking or something like that, and you were talking to a friend and you had other stuff going on, and you're having a good day, it probably would be minimal if you'd even notice it at all. And so we're trying to harness what the brain does accidentally once in a while and teach people how to harness this so that they can do it regularly when they need it. And by doing so, we can actually decrease that experience of chronic pain so that people can continue to do the things that they love. They can be more active with their family. They can engage in hobbies. They can go back to work. If they're still working, they can engage in work and have more fun there, and have it not be something that you slog through because you're just trying to get through the day with the pain levels that you're in, but that you can maybe enjoy what you're doing or enjoy the people that you're around. And so that's kind of the key component, is how different pathways, and we do know that there's pathways, there's emotional pathways, there's physical pathways, and there's cognitive pathways of how people think about their pain. And all of these affect how the volume button of the brain dials up or dials down the pain experiences. And so through the psychotherapy, it's not just about quote unquote coping with pain, you actually change the pain experience. And by doing that, you change people's lives and you help them get their lives back. And that's part of what this psychotherapy treatment does.
So what are the protocols to harness that? How do you go about that?
We divide it into 3 different categories. So some of it is cognition, how people think about their pain. You know, when people think about if they have an incident where they have some short-term pain, you know, they sprain an ankle, they break a leg, you know, there's some pain there, but it's more of a short-term pain. And the body does what it needs to do with short-term pain. There's inflammation to stabilize bones or to stabilize damaged joints. People tend to rest. They tend to isolate. Those are all great things for when it's acute pain. When it's chronic pain, we tend to start thinking differently about the pain condition. So it might be, wait, I can't do that anymore. I can't possibly go there. I can't handle this. And so people suddenly, you know, if you sprain an ankle, it's not going to really change your life goals. It's not going to really change. You might just grit your teeth for a couple of weeks and you're still going to go to class or still go to work or something like that. When people are experiencing chronic, unrelenting pain, then it changes how they think about their pain. It changes how much control they feel about their pain. And so we start pulling that out and start teaching new techniques to help people feel like they have more control over their pain. Because when they feel like they have more control over the pain, they do. And so that's the cognitive component of it. Behaviorally, again, the body does what it needs to do very, very well when it comes to acute pain. We rest, we isolate, sometimes we take a break. But when that translates from acute pain to chronic pain and we're still doing those things, rather than resting for a couple of days or a couple of weeks, suddenly people are laying on the couch for months or years at a time and muscles are getting deconditioned. And so when they do go back to trying to do activities, they're working with deconditioned muscles. And so helping patients get back into slowly engaging in behaviors that are healthy, helping them slowly get back into even basic things like walking around the house or mowing the lawn or walking down to the corner grocery store, all of those pieces, starting slowly so that somebody doesn't have a good day, feel like and then just way overdo it, and then end up back on the couch for days or weeks at a time. In fact, that's called kinesiophobia, is people start becoming afraid of movement because they'll have a good day, they'll overdo it, and then they end up on the couch for weeks at a time. And over time, they go, oh, well, I guess I can't do this anymore. And so, again, it becomes one more activity, one more thing that they take off of their to-do list. So with the behavior piece, we start with a little bit of exercise, a little bit of what's called behavioral pacing, activity pacing, so that people are able to sort of re-engage those muscle groups, slowly get them back into functional order, so that if they want to go and visit a friend, they can handle sitting in a car with low back pain, and maybe they take a break periodically and they don't drive the 2 hours to get there. They take a break partway through and stretch and maybe do a little bit of yoga activities or something like that to make sure that the muscles aren't getting frozen or locked into place. And so we also do some problem solving with them of how would this work for you and how could you see this working. So that's the cognitions, there's the behaviors, and then we also talk about emotions, because if people are having really negative emotions, if they are anxious about their pain, if they're really afraid about their pain, if they're feeling out of control of their pain, and that the only solution that they have to their pain is in this magic little pill, then that obviously is antithetical to helping them move forward with their lives. If they're emotionally angry, if they're very angry all the time, and sometimes pain can make people irritable. I mean, we've probably all been there too.
Yeah, for sure.
If you're not having a good day, people around you tend to know it.
Yeah.
And so so that anger, though, that can also ramp up. Even little things like, road rage. If people are holding on to somebody cuts you off in traffic, and again, you say your few magic favorite words.
Loving kindness meditation.
Loving
meta.
kindness, yes.
That's a big thing with the Airy Bros. We love talking about the loving kindness.
I actually teach loving kindness meditation
Oh, you do?
as part of, not as part of this protocol, but of some of the other protocols that I've done with that. Because if people hold on to that anger, the person that cut you off in traffic, they're 10 miles down the road. They don't care. They're gone. It's any favorite choice words you're saying, they're gone. They're not hearing it. So it's not affecting them. What it's affecting is you, because it's keeping that heart rate high. It's keeping that muscle tension high. It's keeping the adrenaline going. And all of these things open the pain gates, turn up that volume button. So some of this is also working with patients on emotional regulation of making sure that when you have negative emotions, one, that they're worth it. Because, we're not out to say everybody's going to be happy, cheery, rainbow unicorns, blah, blah, blah all the time. But when you have a negative emotion, is it worth it? And what do you do with that negative emotion to make sure that while you're expressing that negative emotion, it's not making your pain worse, or you're not doing something that's actually going to make you experience more pain later on down the road? So those are the three pieces that we use to combat it. Is the psychological pain component, is the cognitive, what do you think about your pain? Behavioral, what do you do with your pain? And emotional, of how does mood affect your pain? Even things like boredom. Because again, if there's nothing interesting happening, sometimes when we work with long-term chronic pain patients, worlds have begun to shrink, and maybe they're not working anymore. Maybe they've lost social networks. Maybe they're not going out with their family the way they used to, or the family is broken up, and the world has shrunk to daytime TV and physician appointments. And of course, that's going to lead to more depression and more anxiety as well. And we know that depression and anxiety are also pain gate. They turn up the volume when somebody's experiencing pain. And so even small things like boredom, and again, that could be cross-cutting. That could be emotional, cognitive, and behavioral all at the same time. But all of these pieces are going to increase pain. So some of that is also working with boredom management. And boredom management not being just channel flipping to see, okay, well, what's on Netflix, or if you're not a cord cutter, then what's on cable TV, and I'm just going to keep flipping through the channels till I find something. That's not catching your interest. That's just trying to be less bored. And so helping people very intentionally say, well, what am I going to do that's going to capture my interest? Now, if there's a favorite movie that you've been waiting to watch, if you've been really waiting for Stranger Things to come on board and now you can binge it because I think it landed July 4th or something like that, not that I'm, but if that's, but you've been really, and you're going to be cognitively engaged in it, sure, that's one thing. If you're just channel flipping, or if you've got something on the TV in the background just because it makes you less bored, that's not going to help with pain. So even boredom management becomes part of what we're doing as part of, again, the behavioral, the cognitive, and the emotional aspects to help the brain dial down that volume on the pain experience that somebody's having.
So you mentioned the meta before with another group. Are you utilizing things like meditation or journaling, for like a boredom practice, as like a journaling activity? Is that sort of stuff that is coming in kind of tools with, I guess, dealing with your pain management or learning? I think, just having the ability to sort of write down, spew on a page or two about, what your pain is actually like, might have a pretty valuable impact on that person or that individual or the group. Are those sorts of things that are coming into the group activities? And
that's a great question. We are not explicitly having people journal, although they're welcome to do so. We do have some exercises where they practice the stuff that we talk about in session that they practice at home, because so much of this is we can talk till we're blue in the face.
Right, you
in
gotta
session.
want it. That's the first and foremost thing.
Exactly.
You gotta wanna help yourself and make the change to get better, or to get off of the opioids, or to learn how to realize that this pain isn't really that big of a deal, or I've dealt with this stuff before.
And that's absolutely. And so the whole point is helping people practice. And a lot of this is like a muscle. The more you practice it, the better you're going to get at it. And so we do a lot of at-home activities of taking the stuff that we talk about in sessions and having people do that at home. And they bring in the worksheets or something like that, and we can talk about what worked for you, what didn't, how can we problem solve to maybe make something work better for you. That's certainly a big part of what we do. We also do a meditation, and the one that we use is a little bit more on the body scan PMR type, and we practice it a lot. And we actually use these small pieces called biodots. They're stickers. And if you ever remember mood rings from the 1970s and the 1990s, where they change color based on the temperature, the colder your hand's in, that means the more stressed that you are, and the more relaxed you are, then it changes colors. And so people can take these home and they can do this relaxation meditation exercise, body scan, and watch how their body responds to it. And so that they can get a very visual experience of like, oh wait, the color of my dot changed from kind of a black to a lighter green. Hey, that's actually a good thing. I'm going in the right direction. And so encouraging more at-home practice, and at-home practice where if somebody has an hour to sit and perform a meditation, that's wonderful. But also a lot of the meditations that we teach are ones that people can do in vivo, in their daily life, that they can practice even if it's 5 minutes at a time. Because what the research is starting to show is that as long as it accumulates to about 20 minutes a day, meditation practice is effective. We don't know why 20 minutes is the golden number. And obviously, if you do more of it, you get more benefit. So if somebody has time to do an hour, that's wonderful. But if people can do 4 5-minute sessions to get to that 20 minutes, or if they do it in a single 20-minute session, that's great. And if you drop too much below that 20 minutes, you just don't seem to have a long-term effect on pain management quite as much. But if people are making that 20 minutes a day mark, then they really are able to maintain lower pain levels throughout the day. And so that's kind of what we're doing with kind of that body scan meditation, is identifying not just what hurts, but more importantly, what doesn't hurt. And how do you appreciate what doesn't hurt?
That's it. That's life, right? I mean, you're always trying to, especially in today's society with social media and instant access to celebrities and superstars and all this, and you're always seeing all these things, and people unfortunately tend to focus on the things that they don't have, as opposed to focusing on the good of what I do have. Like, I have a roof over my head, I have clean water, I put clean clothes on today, like all these things. So that totally resonates with, let's focus on what doesn't hurt today, instead of like always perseverating on my elbow surgery or my neck surgery or whatever it may be. Like, let's focus on the other 85 to 90% of your body that feels really good. I love that.
And part of what you described is a field, it's a relatively new branch of psychology called positive psychology. And it looks at things like gratitude. It does research in gratitude, does research on individuals that have come through a very traumatic experience and yet aren't experiencing PTSD. What's their what are they doing? What's their resilience? How are they managing to come through very negative experiences and still being very positive and being very psychologically healthy with that? And again, it's not a denial of symptoms, because certainly that's not healthy, but what helps keep people happy? What helps keep people moving one foot in front of the other? And so all of those areas of like resilience and gratitude, and focusing on what can make us happy, both short-term and long-term happiness. And there's a lot of neat research that's coming out of that subfield too on pain and opioid use disorder and cravings.
That's interesting. I'm going to take a look at that. You talk about people focusing on the things that feel good or gratitude and all that stuff, and you could probably see a lot of quick changes with people that are buying into that sort of stuff. Are you also dealing with people that are coming in kicking and screaming, or is it people that are like, I'm ready to make this change, I want to get better?
Right now, with the study that we're currently working on, we are embedded in an addiction treatment service. So the patients usually have to come and say, yes, I want to do something with this. By the time they can enroll in the study, they have to have been stabilized on medication for usually about a month or so. And they can be longer than that if they've...
And when you say medication, what kind of...
if they're on like methadone or
Okay.
buprenorphine, or Suboxone's the trade name that often gets used. If they're on what's called medication for opioid use disorder, that they've been kind of stabilized
Okay.
on that. It doesn't mean that they won't have challenges along the way, because everybody's human and everybody struggles, and there may be blips in the road, and we are more than happy to walk with people while they're on that journey. But usually by the time they come to us, they've either because of their own choice or because of maybe a family member that has said, you need to get help for this disorder, or something major is going to change, they're all there nominally voluntarily. So we are working with patients that are experiencing both chronic pain and opioid use disorder, but have made the decision of, okay, nope, I want to keep coming in, or I'm ready to start making a change in my life and reclaim my life.
And are you seeing with these people, because I know I have some friends and just people that I've known that they go in for their standard procedure, knee surgery, back surgery, and then all of a sudden 3 months, 6 months down the road, it's like, I can't get off of this. Is that the majority of the people that you're, unsuspectingly, I just got, 2 dental implants, and then all of a sudden I can't function without these pain medicines?
And we work with patients that are coming into the pain and addiction cycle from a number of different arenas. So they may have come in where they had the pain condition first and had a prescription, and then that got them into that pain and addiction cycle. We may be working with individuals that came in and they had the opioid use disorder first. Maybe they were using heroin, maybe they were using prescription street opioids, and oftentimes that may lead to a more challenging lifestyle that may involve more accidents, may involve more domestic abuse, something that would then trigger a chronic pain condition. Physiologically, once you're into that cycle, it really doesn't matter how you got into that
Right.
cycle. Your body is still craving the opioids, and the person is still experiencing hyperalgesia, which means, again, that escalation of pain. Even though people are taking opioids, there's an escalation of pain in certain areas. There's still cravings involved. There is still social consequences to what the person is doing. There are still financial consequences to what the person is doing. And so while we recognize that there may be many different paths to get to this cycle, once somebody's in that cycle, again, it doesn't matter how they got there. We're willing to walk with them on that journey as they're trying to find a solution to their pain and opioid use.
So we talked about the pain and how we deal with the pain. How do you deal with the addiction to those opioids?
And some of it starts with, let's talk about the physiological component. So some of it's, let's start with education of, the more opioids you take, the more likely you are to get into this hyperalgesia cycle where you're actually going to be experiencing more pain. And I should clarify that I'm not actually anti-opioid. I'm not actually anti-medication in any way, shape, or form. But when people start getting into the cycle, it becomes problematic, and then oftentimes they feel like they can't get out of it. And so sometimes we start with some of the education, like, this is what's happening in your body. And nobody's ever, actually I think every patient I've ever come across in our study, nobody's ever sat down and talked with them about hyperalgesia. Nobody's talked with them about how this might be influencing other aspects of their body, how it might be influencing their brain, how it changes their sleep habits, how it might actually be changing their breathing, particularly in the context of sleep. It might be causing a sleep apnea, for example, where they stop breathing in the middle of the night, which then can cause difficult, cognitive cloudiness during the day, and people not feeling awake and feeling as alert and not being able to problem solve around challenges. And again, more and more reliance on a magic pill to take the pain away or the addiction away. And so starting with some education around that. Also finding out what is motivating them to come through the doors now. Why now? Why not 6 months from now? Why not a year from now? What happened yesterday that made you say, today I'm making a change? Helping them work with those cravings as well. And again, some of that, the body scan, the meditations is part of that, helping with them understand the physiology of it. So when somebody's experiencing an opioid craving, for example, heart rate goes up, blood pressure goes up, pupils change in size, people get a lot of adrenaline. If people are able to have a go-to meditation where they can at least bring the physiology component down, then they can start activating these other problem solvings of like, okay, I need to call a friend. I need to do these techniques. I need to maybe call my counselor. Maybe I need to go to a meeting. If there's somebody that goes to NA meetings, maybe I need to go to an NA meeting. They can slow down the body's response, the desire for craving, so that they can activate all of the cognitive stuff that they've learned through therapy. And so it kind of becomes a two-part process of we teach the problem solving of what do you do when you have a craving. How do you maybe avoid getting into a craving? Maybe there's certain spots that you need to avoid. Maybe there's certain people that you need to avoid. If there's somebody who's, you always used with them, it's tough, but maybe that it's time to let that friendship go if they're not willing to support a sobriety. And so working through the cognitive pieces of, okay, this is the problem solving, this is what you need to do. But sometimes the first step is you got to get the feeling like you're in control of the body again, so that to give all of those thoughts and those problem-solving solutions a chance to kick in. Because otherwise, if you're feeling like you're out of control of your body, your brain's never going to get a chance to kick in and go, yes, maybe I should go to an NA meeting. Let me go look up to see where the next NA meeting is. If you're feeling like you're hyperventilating, you're never going to get to that point.
Would you say most people that you deal with or that come into the studies are out of control of their body, and that's how this happens?
I think there's many different pathways to that. I think by the time I meet with them, they feel out of control. Whether that's how it started or not, different people have different reasons for coming in. But usually by the time they're sitting across from me, they feel pretty much every single one of them would say, yeah, I feel out of control of something. I'm slowly trying to regain control, but I feel out of control of my opioid use. I feel out of control with my pain. A pain flare may come out of nowhere, and I don't know when it's coming, and I don't know why it's coming, and I don't know what to do to fix it. And the pain flares then cause the cravings, and then I'm more likely to use. And so people feel out of control of this cycle and don't feel like they have any tools that they can use, or feel overwhelmed whenever this happens. And so it does happen quite often that by the time they get to the study, they're expressing that sense of, I feel like the only control I have is in, again, that magic little pill.
Those little pills. What can we do to help?
Well, I'd really appreciate you letting me come and talk about this today, because I'm very passionate about this. I think we have to come up with better treatments for patients that are struggling with comorbid opioid use disorder and chronic pain. And so I appreciate you letting me get on my soapbox for that for a little bit.
I appreciate you coming on and sharing your knowledge with us.
And the other thing that I would really appreciate is getting the word out about the study that we are currently doing. And again, it's that STOP study. You don't even have to remember the self-regulation therapy and opioid use disorder and pain. We can just call it the STOP study. And we're actively recruiting for individuals. So it's for men and women, age 18 to 65. And it's 12 weeks of no-cost group therapy sessions And then we'd have 3 additional assessment sessions, and patients will be compensated for their time in the program. They are not charged for the treatment. In fact, they are compensated for their time in the treatment and their travel. And it's a treatment to reduce substance use and pain. If somebody's coming in and they're on medications, we do not change those medications. We do not alter them. We do not require them to come off of them. We would just ask them to be honest with us so that we could monitor what's going on with their medications. And in order to join the study, then you would contact Katie in my lab, and our phone number is 303-315-7036, or through email, it's stopstudy@hotmail.com. So that's the email is stopstudy@hotmail.com. And we look forward to talking with anyone who either themselves are struggling with pain and opioid use, or maybe have a loved one that they want to get a little bit more information about the study to pass on to that friend or family member. We welcome all calls that would be interested in the study, that maybe we can help somebody get the treatment that they need and that they deserve.
So this is open nationwide, or do you have to be here in Denver or Colorado, or?
Right now it has to be in Denver.
Okay.
So they are in-person therapy sessions, so we would need somebody to be coming in. They do get compensated for their travel, because we do recognize that it takes gas and time to come in for that, but we don't actually charge for the therapy sessions themselves. So somebody does need to be in the local Denver area so that they could come in for the assessments and the treatment.
Cool. Awesome. Well, we really appreciate you coming in. This is very, insightful. I think everyone at this point has been touched in some way, shape, or form by this crisis that's going on. Friends, family. I could probably count on both hands. The people, classmates that I went to high school with that have passed because of this sort of stuff. So it doesn't discriminate, you know what I mean? Rich, poor, white, black. It doesn't male, female. It can get a hold of you. So, whenever we have the opportunity to do things like this, to get the word out there, or to try to, put a hand out there to help people, we want to help and get this stuff taken care of, because it can really damage people's lives, and then it also has an impact on all those people around you. So we really appreciate you coming in to talk about it, and hopefully we can get you some phone calls and some emails and get some more people in there so we can help them out.
Thank you so much. I appreciate it.
Absolutely. Prince, you got anything?
No, I just appreciate your time and your knowledge. Definitely had some light bulbs go off today, so thank you very much, Doctor.
Appreciate it. Appreciate the time that you guys gave me to stand on my soapbox about
Absolutely.
something I'm passionate about.
Yeah, and we'll get some more information from you, and then I'll put everything in the show notes as well, so that when people get the link and it pops into their iTunes, they have that information there. So,
Great.
cool.
Thank you.
Thank you.